Let's start up.
Today's topic is evaluation of cardiac status in neurological illnesses, a critical appraisal. My name is Mayur and my moderator is Sapna madam. And the outline of this session we will be discussing regarding cardiac status evaluation in certain neurological diseases and the mechanisms which link neurological diseases to the cardiac effects. And further, we'll also be briefly discussing upon the diagnosing and monitoring of the cardiac effects in these neurological patients. We will be discussing in the sequence of diseases which occur in diseases, that is stroke, epilepsy, neuromuscular diseases, and other degenerative conditions like Parkinson and Alzheimer's disease briefly, and multiple sclerosis also. The cardiac evaluation is stroke. The proportion of ischemic strokes generally considered to have originated from the cardioembolic sources has increased dramatically with the development of sophisticated technology, and which has the capability of defining cardiac and vascular lesions. Cardioembolic stroke is now estimated to be responsible for up to 20% of the ischemic strokes. Coming to the TOAST classification of the sources of cardioembolism, it can be divided into high-risk sources and medium-risk sources. High-risk sources include etiologies such as mechanical prosthetic valve, mitral stenosis, sick sinus syndrome, dilated cardiomyopathy, infective endocarditis, and other etiologies. And medium-risk sources include mitral valve prolapse, mitral annulus calcification, atrial flutter, patent foramen ovale, and atrial septal aneurysm, and other causes as mentioned. And myocardial infarction of more than 4 weeks comes under medium risk source. And a recent myocardial infarction comes under a high risk source. The cardiac evaluation is stroke. Further discussing, we can see that the emboli arise from a varied diseases that affect the valves, the rhythm of the heart, the endocardial surface, and myocardium also. It is important to take a careful history in which we can particularly seek the symptoms of arrhythmia, congestive heart failure, angina pectoris, or any prior MI. The heart should be carefully examined for the quality of the sounds, the rhythm of the heart rate, the heart, presence of gallop, or any characterizing murmurs. ECG and X-ray are the investigations which have high screening value, safety, and low cost. In ECG, we can see different types of arrhythmia and any MI evidence of MI also. Coming to the next investigation, the role of echocardiography in stroke. These are the situations in which echocardiography has a high yield in ischemic stroke patients. In a patient of known prior heart disease, if the clinical course is suggestive of brain embolism, that is the sudden onset of deficit without any history of prior TIA, a history of peripheral embolism in the limbs or in the abdominal viscera, and any young patient who presents without any known atherosclerotic risk factors. The preliminary investigation results in which the yield of echocardiography is high in ischemic stroke patients are as follows. The absence of an extracranial or intracranial vascular disease or on non-invasive testing. The presence of a superficial infarct on the imaging, either CT or MRI, and the distribution of a peripheral branch. The presence of hemorrhagic transformation of a brain infarct in a single vascular territory. Imaging showing multiple infarcts in multiple vascular territories. A normal brain imaging in a patient whose clinical deficit and the imaging findings are not compatible with lacunar infarct, and any angiography that shows distal cutoff of brain arterial branch with or a luminal filling defect without severe proximal stenosis. Coming to the further role of echocardiography, we have transthoracic and transesophageal. Transesophageal is definitely superior to transthoracic, as we can visualize atrial lesions, occult valvular disorders, and ulcerative lesions of the proximal aorta. The proximal aorta is often missed by transthoracic echocardiography, and transesophageal has a higher yield in detecting them. It is superior for evaluating the aortic arch, the left atrial appendage, the aortic valve, and the atrial septum, but it is more invasive than transthoracic echocardiography. The significance of finding a patent foramen ovale, which is usually present in 25% of the general population, but overrepresented in cryptogenic stroke, is a debatable statement. And the presence of an atrial septum aneurysm and large volume shunts have been associated with higher risk of stroke recurrence. There are a few pitfalls in the echocardiography because the transesophageal echocardiography also may not be able to identify a potential source of cardiac embolism because some thromboemboli are too small to be detected. A 1 or 2 mm size of an embolus, which could produce a devastating neurological defect, but the size of the particle is often beyond the resolution of the echocardiography, which could detect the embolus. Another major reason of failure to show a thrombus is that the thrombosis and embolism are dynamic processes. During the time when we are doing the investigation, if there is no particular thrombus, then we may miss the thrombus and the diagnosis. Coming to the imaging of the aortic arch, transesophageal echocardiography also yields important information about the proximal aorta, which is often missed by transthoracic echocardiography. I particularly mention regarding substantial aortic arch atheroma, which is indicated by a plaque thickness of greater than 4 millimeters or a mobile plaque. These both are independent risk factors for recurrent stroke. Here we can see a diagram in which the aortic arch has been shown in the lightly shaded region, which is actually behind the manubrium and not in reach of the transesophageal echocardiography also. We can see that CT angiography has a 40%, a 62% sensitivity, which is 5 times greater than the transesophageal echocardiography detection of this region. And coming to the recommendations on structural imaging, echocardiography with or without contrast is a AHA class 2A recommendation for evaluation of a cryptogenic stroke. Transesophageal echocardiography, cardiac CT or cardiac MRI of the patients with embolic stroke of unknown source is an AHA class 2B recommendation. Coming to the next investigation, if we look into the extended rhythm recording, ambulatory ECG, that is Holter, which can be done up to 24 days, starting from 24 days to up to 30 days. There are also loop recorders which can be implanted under the skin of the chest to record the heart's electrical activity. These devices continuously store information in their circular memory, that is the loop, as ECGs. The arrhythmias are recorded by freezing a segment of memory and it can be reviewed later. Usually up to 3 episodes of abnormal activity can be stored and the most recent episode replaces the old one. This can monitor the heart rhythms for a year or even more are also available commercially. Coming to long-term follow-up of detection of AF, here I would like to mention regarding a crystal AF trial which was published in NEJM. This study had studied adults of more than 40 years and within 90 days of cryptogenic stroke after the standard workup, including a 24-hour monitoring of Holter monitoring for AF. The long-term ECG monitoring with an insertable cardiac monitor was done. And it was the groups which are compared are conventional follow-up, that is site-directed intermittent ECG, Holter, or event monitoring, was compared to a continuous monitoring with the insertable cardiac monitor. And the outcomes that were measured in this were the time to first episode of AF was seen. That is, the AF was defined as more than 30 seconds of the event. And at 6 months, it was seen that in the patients who had that is the intervention group which they had considered had shown 8.9% was when compared to 1.4 in the standard group. Means the group which was under the standard care. And at 12 months, it was 12% when compared to 2% with the standard group. And at 36 months, it was 30% compared to the standard group, which was 3%. The median time to detection of AF was 41 days at 6 months. And many episodes were asymptomatic, that is up to 75% of the episodes were asymptomatic in this trial. Coming to one more trial, Embrace trial, in which they had seen the primary outcome such as the detection of atrial fibrillation with duration of more than 30 seconds within 90 days. Here also, the intervention group had 16% when compared to the control group, which had only 3% of detection of atrial fibrillation. The next coming to the next part of evaluation with biomarkers. The biomarker testing has been studied to identify those patients who likely to have or likely to develop atrial fibrillation. A high level of NT-proBNP seems to be useful in detecting the presence or a risk of atrial fibrillation in the patients. Here are the conditions which I have listed, which can lead potentially to stroke: atrial fibrillation, valvular disease, pyroprostatic or prostatic valves, infective endocarditis, PFO, non-bacterial thrombotic endocarditis, acute MI with left ventricular thrombus, heart failure, or aortic arch atherosclerosis. Next, I would like to describe regarding an entity called as atrial cardiopathy, in which it is defined as pathological atrial substrate, which can potentially cause embolic stroke even in patients without atrial fibrillation. The biomarkers of atrial cardiopathy are the measurement of NT-proBNP within 48 hours of more than 250, and ECG parameters which include the P wave duration, PR interval, and entity called as P terminal force in V1. In the diagram, we can see how to calculate the P-terminal force in V1. The amplitude of the inverted wave, that is usually when P wave is biphasic in V1 lead, we draw a straight line with the isoelectric line, and the amplitude we measure and multiply it with the duration in milliseconds. The cutoff value is 4,000 for this. If more than 4,000, then it can be considered as a positive indicator, positive biomarker for atrial cardiopathy. Coming to the third component, there is a left atrial enlargement, which is more than 37 millimeters in women and more than 39 millimeters in men. And left atrial volume, that is more than 34 ml of meter square of body surface area. I would like to show a representative case which I had seen in our center. The case is a 52-year-old female who had presented to us with right upper and lower limb weakness with slurred speech since she woke up at 4:30 a.m. But she had presented 1 hour after noticing the symptoms, and seen on examination, when she arrived 7.5 hours later of the onset of symptoms, she had no deficits with a GCS of 15 and 15 out of 15. NIHSS was 0. She had presented out of the window period and was not a candidate for thrombolysis. Here are her imaging features in which we can see a left MCA territory acute infarct with early changes in flare were also seen, and angio was showing distal M1 MCA occlusion and hypoperfusion of the MCA territory. Even though this patient had no deficit, she had a major intracranial vessel occlusion with significant perfusion mismatch, and then she was considered for a mechanical thrombectomy in the view of a possible worsening. So it was a mechanical thrombectomy was done, and TK3 recanalization was achieved, and no periprocedural complications were seen. Further, we had evaluated her for the cause of her etiology of her stroke, in which ECG showed normal sinus rhythm. An echocardiography transesophageal with bubble contrast had shown small PFO with right to left shunt on Valsalva maneuver, and no atrial aneurysm was seen. Lower limb Doppler was normal, and TCD bubble study showed only few hits. Here I would like to mention the rope score, which we use to characterize the need of surgical correction for PFOs. The characteristics which we see in rope score are history of hypertension, any history of diabetes, any history of stroke or TIA, being the patient being a smoker or non-smoker, and cortical infarct of imaging. And each one is given 1 point, and the age as it increases, the score of which we attribute to it in rope score decreases. The maximum score that a patient can get is a less than 30 years individual with no hypertension, no diabetes, no prior stroke or TIA, non-smoker, and with a cortical infarct. Further, there is a Pascal classification system which identifies a PFO related the probability of a PFO related stroke. A high rope score, that is more than 7, and high risk feature of PFO is seen. A high risk PFO is defined as a defect of foramen ovale larger than 3 mm and or an atrial septal aneurysm which demonstrates hypermobility of the septum during Valsalva maneuver, leading to a significant increase in the PFO size. And the PFO related stroke, if both of the high risk features and high rope are present, then it is considered as probable. Either one of is present, it is considered as possible. And when both of them are absent, then it is unlikely to be a PFO related stroke. And the patient that we had seen had a low rope score, so we did not consider her for a PFO closure. Coming to the stroke effect on heart, this is the bidirectional. There is a bidirectional effect relationship which has been implicated. As cardioembolism affects brain by causing stroke, there is also effect of stroke on the heart, which can be manifested as development of arrhythmias during the acute phase. The most common arrhythmia is just seen is atrial fibrillation, and also there is increased risk of thromboembolic events which causes stroke recurrence. There is also stroke-related damage to myocardium or neurohormonal disturbances, which can precipitate acute or chronic heart failure. Further coming, there can be also ischemic heart disease because it is exacerbated by shared risk factors for both stroke and this ischemic heart disease, that is hypertension, diabetes, and dyslipidemia. There is a bidirectional relationship implicated as mentioned, and there is a need of comprehensive care that addresses both neurological rehabilitation and cardiovascular risk management, and it is crucial for enhancing patient recovery and minimizing complications. The heart-brain interactions can be manifested in the following way. Neurological effects of cardiac disease could manifest as cardioembolic strokes due to AF or LV thrombus, and heart failure and aortic stenosis can also lead to cognitive impairment. Coming to the cardiac effects of neurological disease, there is a particular entity called stroke heart syndrome, which I'll be mentioning now, in which myocardial injury and infarction can be seen, along with LV dysfunction can be seen, atrial fibrillation or any other arrhythmias can be seen, and a neurogenic sudden cardiac death can be seen. The other manifestations could be neurogenic pulmonary edema, neurogenic cardiomyopathies such as Takotsubo, and ECG changes in intracranial hypertension, that is deep T inverted waves and QT prolongation along with STD changes, or the occurrence of a sudden cardiac death. This is the pathophysiology of the stroke heart syndrome that I was describing about. There is a neurogenic cascade which is triggered, and there is altered vagal tone also. And due to the sudden catecholamine surge and systemic and local inflammation which set in, the heart is affected in the forms of myocardial injury or acute myocardial infarction. There can be a presence of sudden cardiac death and appearance of ECG changes in arrhythmias. Most common, as we discussed, would be AF, and LV dysfunction with occurrence of Takotsubo syndrome also can be seen. These are the neuroanatomical correlates in the stroke heart syndrome. The right anterior insular cortex infarction is strongly associated with troponin release, and the involvement of right insula, frontal and parietal cortices, amygdala, basal ganglia, and thalamus could result in post-stroke arrhythmias. Coming to this brain-heart interaction, I would like to mention one more case which was reported from our center. It was a sinus arrest which was complicating acute post-cerebral artery stroke. Here we can see the tracings in which the sinus cycle length showed progressive prolongation of the 4 beats, which preceded a prolonged pause, which of 13.24 seconds, 13 seconds. And similarly, the recovery of sinus activity was also associated with a transient phase of sinus bradycardia, as it was evident in the saturation probe. And in addition, in the event review panel, which we can see below, in the lower half of figure, it shows the occurrence of another episode of extreme bradycardia that is less than 30 beats per minute, almost 1 hour, that is 11:30 to 12:30, 1 hour before this event which was recorded and mentioned. Hereby I complete the cardiac evaluation in stroke, and coming to the cardiac evaluation in epilepsy. Individuals with epilepsy face a 2 to 3 times greater risk of early death as compared to the general population, with approximately 15% of these deaths occurring from sudden cardiac death or acute MI. The length of epilepsy with recurrent seizures is associated with the progressive cardiac damage. We know the entity of SUDEP, which represents a substantial cause of mortality among epilepsy patients and is often associated with cardiac arrhythmias occurring immediately after or during the seizures. Here is a pictorial representation of SUDEP, in which it causes 3,600 deaths per year, and a sudden cardiac death in epileptic heart, the cause of the number is up to 16,000 per year. And there is a significant overlap as shown in the Venn diagram, because the pathophysiology implicated is autonomic modulation due to decreased sympathetic activity and increased parasympathetic activity. And decreased seizure is due to hypoperfusion, paradoxically, which occurs later in the epilepsy, and increased cardiac stability is also implicated. Coming to further cardiac evaluation in epilepsy, the sudden and unpredictable natures of seizures can precipitate cardiac dysrhythmias, including VT and VF, and it could have fatal outcomes. The seizures disrupt the autonomic nervous system regulation of heart rate, blood pressure, and vascular tone, which could result in profound cardiovascular effects. These disruptions can manifest as bradyarrhythmia, such as sinus bradycardia or AV block, as well as tachyarrhythmias, such as supraventricular tachycardia or AF. There is a concept proposed of epileptic heart, in which chronic epilepsy could lead to repeated hypoxemia and myocardial ischemia, and the cardiotoxic effects of excess catecholamines, which uh, keep surging during the episodes of epilepsy. And VNS protection, that is vagal stimulation protection, is impaired, and ultimately it leads to stiffening of the myocardium and myocardial stunning. And there is a myocyte vacuolization and internal fibrosis due to the chronic repeated injury. And also due to the accelerated atherosclerosis, there is cardiac electrical instability. A concept of T-wave alternance has been mentioned by Verrier et al., and that I will be describing shortly. Verrier et al. Had also mentioned regarding the 12-lead EKG features of epileptic heart, in which we can see each component of the ECG has been mentioned to show abnormalities. The P wave showing atrial fibrillation or enlargement, and the prevalence of this is up to 10% in the epilepsy patients. The STT changes such as depression, which are indicative of ischemia, were seen in a study up to 40% of seizures. Presence of Q waves, which indicate a prior silent myocardial infarction, show up to a five-fold risk increase in MI in patients of epilepsy. And coming to the QT interval, there is prolongation and dispersion, and increased susceptibility to ventricular arrhythmias. And up to a third of the patients with drug-resistant epilepsy were seen to have this QT prolongation. Coming to when we consider the effect of epilepsy on cardiac function, we should also emphasize on effects of anti-seizure medications, particularly sodium channel blocking agents at high doses in combination with other sodium channel blocking agents. These were reported to cause cardiac arrhythmias even in the absence of a pre-existing cardiac disease. The chronic use of particularly older generation ASMs like phenytoin or carbamazepine may contribute to cardiovascular complications through mechanisms such as QT prolongation or metabolic disturbances. Coming to, if we raise the question whether ASMs can increase this risk for sudden cardiac death or not, this was found in a study by Bardai et al., which was published in Heart in 2015. There were it was mentioned as it could be a risk factor for sudden cardiac death independent of epilepsy, because they had compared sodium channel blocking non-sodium channel blocking agents, and the odds ratio when it was adjusted for heart failure was 3, and odds ratio when adjusted for epilepsy was 2.8. This, when compared to the non-sodium channel blocking agent, was also showing an odds ratio of more than 1, but the confidence interval was including 1, which renders it insignificant. And the sodium channel blocking agent showed significant confidence interval in both adjusting for heart failure and adjusting for epilepsy. There were 926 sudden cardiac death cases, and up to 10,000 controls were seen in this study. We had a 2012 and between 2012 and 2013, a cross-sectional study was done and published from our center, and it showed metabolic syndrome in young adults with epilepsy. 183 adults in between the age of 20 to 49 were included in the study, and the conclusion of the study was valproate was associated with a higher metabolic risk, metabolic syndrome occurrence risk of up to 43%. Coming to the microvolt T wave alternates, which I had described in the epileptic heart concept as a cardiac electrical instability. This was also mentioned by Verrier et al., and they had described a recording from a patient with coronary artery disease who had died suddenly at 1 year after this recording was made. Here we can see that the morphology of T in A, which has been mentioned as A and B, on separately weaving, it doesn't show much of a difference, but when we superimpose both of them, there is a beat to beat variability when where the A is steeper and B is more flatter. And here they had mentioned that the greater the separation, the greater the risk. The cutoff which was mentioned was 47 microvolt, and it can be detected by usage of ambulatory patch monitoring, which are commercially available. And more than 47 microvolts had a greater risk of sudden cardiac death, which could occur in patients of epilepsy. I would also like to mention regarding possible pathways which could mediate cardiovascular risk in individuals with epilepsy. The involvement of amygdala has been reported to have increased risk of cardiovascular events, and medial temporal lobe epilepsy involvement has independent association with longer disease duration, and it alters the feedback modulation of heart rate variability, and also the function of amygdala is affected by involvement of medial temporal lobe epilepsy. Now, I would like to describe two cases regarding cardiac involvement in epilepsy. Coming to the first case, it was a 76-year-old male with hypertension and dyslipidemia had presented to us with recurrent daily paroxysmal events. He had most events which occurred in sitting forward position and few events during supine posture, but which he had described as blurring of vision with losing of touch to the surrounding, and along with followed by profuse sweating during episodes. There was no specific provocation factors, and each episode lasted less than a minute. And These presyncopal attacks, we were suspecting it as a presyncopal attack, and we had done a video EEG for this patient for characterization of his events, which had showed these three right-sided frontotemporal slowing and a query left temporal SRIDA was seen. And there were recorded 8 focal seizures and 1 electrographic seizures of right temporal origin. Actually, regrets that I could not attach the tracing of this video EEG. And because the correlation of the tachycardia as was along with the occurrence of this epileptiform discharges, this patient was labeled as a arrhythmogenic seizure. We had managed this patient as by optimizing his anti-seizure medications and adjusting the doses according to his seizure frequency, and then he had improved symptomatically. Coming to the evidence which shows us that temporal epilepsy can cause arrhythmias, a study in 2015 was published by Van der Lende et al. Of 162 patients, in which ictal asystole was mentioned as the most common arrhythmia which could occur in temporal epilepsy. But tachyarrhythmias were also mentioned. Out of the 162 patients, 3 were reported to have ventricular fibrillation, and 14 were reported to have post-ictal fibrillation or atrial fibrillation or flutter. A second case I would like to mention is of a 23-year-old female with a 2-year history of focal seizures with secondary generalization. She did not have any history of childhood events or febrile seizures, and the onset of seizures in clusters were up to 6 per day. The initial frequency was once in one cluster per 6 months, but it gradually increased to one cluster per week. And the semiology was initially she used to have an epigastric discomfort aura and followed by searching eye movements with a confused look, which was followed by fast jerky movements of the right hand and chewing and swallowing movements. And there was a post-ictal speech arrest for about 1 minute. Some of these events were also started with a couple of jerky movements of the both shoulders, and it was followed by a falls. She had also sustained injury during the falls, and she was on levetiracetam, lacosamide, and clobazam. And on investigation, her MRI had shown atrophy of the left hippocampus with T2 hyperintensity within and associated widening of the adjacent temporal horn. And the volumetry showed left hippocampal volume of 1.7 when compared to 2.5 on the right side. And the EEG, which we can see, showed the onset of the ictal rhythm in left temporal region, which then spread to the left hemisphere, which is concurrent with the bradycardia, which was lasting for 3 to 4 seconds. The neuropsychological testing of this patient also showed impaired verbal memory scores, which were again suggestive of left temporal involvement, and a detailed cardiac evaluation, including 2 LED ECG and 2-dimensional echocardiograph, along with a 48-hour Holter monitoring, was normal. This evidence was because of this available evidence, the localization of his seizures to his left temporal lobe was done, and the concordant data on MRI and neuropsychological testing showed left temporal lobe involvement with this ictal bradycardia and asystole were considered likely to be an autonomic manifestation of the temporal lobe seizure because there was no underlying abnormality of cardiac structure or rhythm. Here was an evidence which supports the the hypothesis for the previously mentioned case, which was published in 2015 in AHA Journal of Circulation. The title of this was Ictal Asystole, whether it is a life-threatening vagal storm or a benign self-limiting termination mechanism. The ictal asystole is likely due to vagal storm from stimulation of the central autonomic network, which includes insula, amygdala, or hippocampus. And both left and right hemispheres are implicated in this occurrence. And the sequence usually is seizure onset, which is followed by initial tachycardia, and it later leads on to progressive bradycardia and asystolic pauses. These events can mimic vasovagal syncope, but there should be a concurrent EEG, or else it is difficult to differentiate these events as ictal origin without EEG. These study had also mentioned that ictal bradycardia and asystole are seizure-induced cardiac arrhythmias, which are rare phenomenon and are documented in fewer than 0.5% of the patients, even those patients which undergo video EEG monitoring. Most of these cases occur during focal seizures, which are often of temporal lobe in origin. The seizure activation of the central autonomic structures, as mentioned, notably insula and amygdala, cause triggering of the vagal stimulus, that is parasympathetic storm, leading to parasympathetic storm, and marked heart rate slowing or asystole. Both the right and left are capable of triggering these events, and cerebral ischemia from prolonged asystole may paradoxically terminate the seizure itself. Hereby, I complete the cardiac evaluation in stroke and epilepsy. Coming now to cardiac evaluation in neuromuscular disorders. I would be like I would like to discuss regarding the following diseases: DMD, LGMD, myotonic dystrophy, mitochondrial cytopathies, and including other myopathies also. Coming to the DMD, there is age-wise progression of the cardiac involvement, which has been described in Duchenne muscular disease. Normal heart is seen in up to 74% in ages of less than 6 years, and virtually it is zero of patients of more than 18 years. And particular of interest, dilated cardiomyopathy incidence increases and it reaches up to 71% in the patients who are of more than 18 years of age. The cardiac workup in DMD shows us large R waves in V1 and V2 in the EECG and Q waves in the inferior leads. Coming to the echocardiography, it shows ventricular dysfunction and left ventricular dilatation. The current recommendations for cardiac workup in Duchenne muscular dystrophy are: initially it has to be done at diagnosis, and if the patient who presents to us is less than 10 years, then every 2 years the screening has to be done, and it has to be done annually if the patient who presents us is more than 10 years at initial presentation. Coming to cardiac evaluation is in LGMD. In LGMD type 1B, that is laminopathy, there are incidences of arrhythmias and conduction abnormalities. And in sarcoglycanopathy, that is LGMD 2C to 2F, there is a DCM phenotype which is more prevalent. And Fukutin-related proteinopathy also presents to us with a DCM phenotype. The current recommendations, as mentioned in AHA American Heart Association guidelines, are in patients with LDMG, complete evaluation, which includes the examination ECG and echocardiography, should begin at the time of diagnosis. And there is a class 1 recommendation with level of evidence C. Coming to cardiac evaluation in Friedreich ataxia, there is a high risk of arrhythmia with hypertrophy of the left ventricle, and AF is also seen in patients of Friedreich's ataxia, and it is the most common cause of death, which amounts up to 15%. And there is also myocardial fibrosis with concentric LVH and dilated cardiomyopathy with fibrosis regression, and it may also require cardiac MRI to see for the occurrence of fibrosis in the cardiac fibrosis in these patients. And the same guidelines recommend a class 1 recommendation of evaluation at the time of Friedreich's ataxia diagnosis and with the level of evidence of C. Coming to cardiac evaluation in uh, uh, the cardiac evaluation in myotonic dystrophy, there are conduction abnormalities of PR interval of more than 240 milliseconds and QRS prolongation can be seen, and AV block. These are the common cardiac conduction abnormalities. Along with that, arrhythmias which include atrial fibrillation, ventricular tachycardia, supraventricular tachycardia are also seen. And sudden cardiac death is also a major risk in the patients of myotonic dystrophy. However, dilated cardiomyopathy and heart failure are less commonly seen. Coming to the recommendations in myotonic dystrophy, the standard cardiology evaluation should occur at the time of diagnosis, regardless of the symptoms of which the patient presents. Again, this is a class 1 and level of evidence is C recommendation. The other myopathies with cardiac risks are FSHD has a low risk of cardiac involvement. The other LGMDs like tendinopathies present with dilated cardiomyopathy, and other arrhythmogenic cardiomyopathies like desminopathy presents with ICD, and the dystrophia myotonica type 2 is similar to type 1 but is milder in its presentation. And filamin C and amironopathies are also present to us with ICD. Coming to case scenarios, the first case which I want to like is we had seen a 23-year-old lady with normal birth and development history who had presented to us with at 15 years of age with chronic progressive ptosis and unsteadiness of gait along with limb ataxia. She had episodes of transient loss of consciousness which was suggestive of syncope, and 5 episodes over 5 months which was followed by a 2-month history of speech disturbances and a nasal twang in speech and mild difficulty in swallowing. On examination, she had short stature with bilateral near complete ptosis without any fatigability, and her fundus was showing pigmentary retinal changes. And she also had neck flexion weakness with distal hypotonia, and cerebellar abnormality was seen, that is dysmetria and dysdogokinesia of the left side, along with impaired tandem gait. On evaluation, her cardiac involvement was objectively seen in the ECG with bradycardia, and MRI was showing mild cerebellar valvular atrophy. Other than that, there were no imaging findings which were seen in this patient. Coming to the investigations, the ANMG and RNS was normal, and her serum lactate level was elevated, with the rest of the investigations being normal, except the ECG, which showed complete heart block with a heart rate of 40. As the patient had presented to us with an onset of less than 20 years and a progressive external ophthalmoplegia along with pigmentary retinopathy, there was also cerebellar ataxia and cardiac conduction defects. This was a diagnosed case of Kern-Sayre syndrome. And the management of this patient that we had done is a permanent pacemaker implantation. On follow-up, the patient was symptomatically better. I would like to mention regarding another case of a 40-year-old female who was presented to us with myasthenia gravis. She was not a known case of diabetes or hypertension. She had undergone a complete surgical removal of invasive thymoma 2 months prior to our presentation to our center. Was prescribed on pyridostigmine and neostigmine. She had acute generalized worsening of muscles and impending muscle paralysis. And at admission, initially she was hemodynamically stable and her cardiovascular examination was essentially normal. On day 2 of hospital admission, she had acute pulmonary edema along with hypotension, and she required management with mechanical ventilation and inotrope support, which was given with dopamine infusion. And on her further evaluation, her ECG was when on admission was normal, but later was showing T-wave invergence in the anterolateral leads without any significant STT changes. These were quite unremarkable considering the clinical picture of pulmonary edema and the severity of the cardiogenic shock. But further evaluation had showed TROP-T positivity, and serial CK-MB was done, which remained in normal limits. She underwent a transthoracic echocardiography on day 3, which revealed a dilated left ventricle with akinesia of apical segments, as shown in these figures. The end systolic frame of the left ventricular angiogram in right anterior oblique projection showed the peculiar shape reminiscent of Takotsubo. And the second picture shows dilated left ventricle, and the third picture shows angiography in which the coronaries have been shown to be normal. The ventriculogram in the end showed apical ballooning, which was resembling a pod. The basal segments were hyperkinetic and the epicardial coronaries were normal. This was classical of a Takotsubo syndrome, and this had been reported from our center as a Takotsubo cardiomyopathy in patient of myasthenia gravis, a rare clinical association in 2009 in BMJ. Coming to evidence for these same presentations in myasthenia gravis, Takotsubo syndrome was mentioned in a systematic review of 16 cases. The mechanism that they had described is usually the Takotsubo occurs in myasthenic crisis because it leads to a severe stress. There is a sudden adrenergic surge, and it leads to myocardial stunning via vasospasm and microvascular dysfunction. The ultimate catecholamine toxicity causes transient LV dysfunction. The risk factors for this were mentioned in this systematic review were the presence of older age, having a female sex, and emotional or physical stress, which was precipitated as myasthenic crisis in these conditions. And the presence of thymoma and other comorbidities such as hypertension or atrial fibrillation could also have a higher risk of presenting with Takotsubo syndrome or any other involvement of in the patients of myasthenia gravis. Coming to other neurological diseases, I would like to briefly mention regarding the evaluation in these diseases. The cardiac status in Parkinsonism disease, as this is a progressive neurodegenerative disease, it presents with severe autonomic dysfunction, and the autonomic dysfunction plays a crucial role in shaping its cardiovascular manifestation. And aging also has been shown as a significant risk factor for both cardiovascular illness and Parkinsonism disease. The cardiovascular abnormalities in Parkinsonism patients are related to dysautonomia. Autonomic dysfunction, as widely accepted, is a non-motor involvement in Parkinsonism disease that occurs long before the appearance of standard motor signs and symptoms. And the long-standing presence of this dysautonomia can lead to cardiac manifestations in these patients. And orthostatic hypotension, which is usually seen as a feature of dysautonomia, not only increases the risks of falls and syncope, but also poses daily challenges for the patients and which affect their mobility and quality of life. The patients with Parkinsonism disease are at high risk of developing heart disease as a effect of their side effect of their medications, as levodopa itself can exacerbate orthostatic hypotension, and the other dopamine agonists which can cause restrictive valvular diseases is also well known. Coming to Alzheimer's disease shares common risk factors such as hypertension, diabetes, and hyperlipidemia with cardiovascular diseases. The presence of these comorbidities complicates the management of both cognitive and cardiovascular health in affected individuals. Vascular pathology, which has been also implicated in Alzheimer's disease, plays a crucial role in exacerbating the cognitive decline in Alzheimer's patients. These risk factors contribute to a higher incidence of cardiovascular conditions such as coronary artery disease, heart failure, atrial fibrillation in individuals with Alzheimer's disease. I would like to again also mention regarding cardiac status in multiple sclerosis. Multiple sclerosis can significantly impact cardiovascular health through various mechanisms such as brainstem lesions and chronic inflammation. The MS-related lesions, especially in the brainstem, disrupt the central autonomic pathways, which cause abnormalities in heart rate variability and blood pressure regulation. This autonomic dysfunction can manifest as, again, orthostatic hypertension in these patients also, arrhythmias, impaired baroreflex sensitivity, and could affect cardiovascular stability and increasing the risk of adverse events in MS patients. These autonomic dysfunctions appear to be associated with disease duration and to be more common in progressive forms of MS. And when involvement of limb stiffness and weakness in patients of MS again leads on to a sedentary lifestyle, which can again is a vicious cycle in which cardiac, which is again a contributory to cardiac coronary artery disease development. And these autonomic dysfunctions do appear to be associated with the disease duration and to be more common in progressive forms of MS. Uh, this Actually, I had mentioned regarding only evaluation and not touched upon the management and uh, the implications of management, because the topic was only regarding evaluation of cardiac status. Uh, okay. I would like to briefly touch upon the mechanisms which can link neurological diseases to cardiac effects. We had already discussed regarding the autonomic nervous system dysregulation. Also, inflammation, genetic factors, and medication side effects are also implicated in cardiac dysfunction. The neurological diseases which frequently disrupt the autonomic nervous system, that are stroke, epilepsy, MS, and Parkinson disease, we have already discussed regarding. Coming to the inflammation, interleukin 6 and TNF alpha promote endothelial dysfunction and accelerate the atherosclerotic process in cerebral and systemic vasculature. The direct effects of inflammatory mediators on myocardial tissue, including oxidative stress and fibrosis, can impair the contractility and contribute to the development of heart failure. The synergistic effects of neuroinflammation and vascular endothelial damage contribute to a heightened susceptibility to cardiovascular events. And the presence of genetic factors such as mutations in lipid metabolism, for example, ApoE genotype, and ion channelopathies such as SCN5A mutation can cause both involvement of cardiac and cerebrovascular CNS present with CNS manifestation, and inflammatory pathways such as TNF alpha polymorphism. All these mutations can predispose the individuals to conditions such as familial hypercholesterolemia and familial amyloid polyneuropathy, which manifest with neurological and cardiac involvement. And these shared genetic pathways highlight the intricate interplay between neurological and cardiovascular health and underscore the importance of genetic screening and identifying at high risk individuals. And again, medication side effects, as we discussed, the anti-epileptic drugs such as carbamazepine, phenytoin are well known to prolong the QT interval, potentially increasing the risk of ventricular arrhythmias and the possibility of a sudden cardiac death. Other antipsychotics such as haloperidol and risperidone, which could cause QT prolongation and are widely used in neurological conditions, can also lead to cardiac side effects. So, for diagnosis and monitoring of cardiac side effects in neurological patients, a comprehensive screening is essential with regular assessment of the traditional risk factors and assessment with ECG and echocardiography. And in required conditions, we can also offer the patient to undergo Holter, which offers continuous ambulatory ECG monitoring to detect arrhythmias and evaluate heart rate variability.
So, some of you laughing. So, Mayur has, this is a very vast topic. Like if it was confined to stroke and heart or like epilepsy and heart, it would have been more precise. But since the topic is vast, I think Mayur has done his maximum to do justice to the topic. Uh, Regarding the individual topics like stroke and heart, we know that most of the literature, if you look at the involvement of cardiology, interaction between cardiology and neurology, most of the literature is regarding heart and stroke, and some there is a lot of literature on epilepsy and neuromuscular. That is why we concentrate on these three conditions. So regarding stroke heart interaction, we know that there are some cardiac substrates which can predispose to stroke, and the stroke itself can affect the heart in during acute phase and also long term. So those things Mayur has already elaborated. There are the major cardioembolic substrates. In the initial slide, the TOS classification, that was an older classification where low atrial fibrillation and all has been separately addressed. But now we know that there is atrial fibrillation. In regard to stroke, there are now the recent literature suggests that there may be two different. One is a non-atrial fibrillation, somebody with an atrial fibrillation before developing a stroke, and another entity which is increasingly being recognized now is atrial fibrillation detected after stroke, that is FDAS. You must have read about Sposato's articles and all regarding FDAS. So that there is emerging literature that there is has less of cardiovascular risk factors, like the substance have less cardiovascular risk factors. They are of younger age, and their future stroke risk when compared to non-atrial fibrillation may be less. So there are and this is increasingly being recognized with long-term rhythm monitoring available. And that also Mayur has shown, like when you increase the duration of recording from 24 hours to 7 days to 30 days and a long-term implantable recorder, how the atrial fibrillation pickup increases. And another significant important thing is the duration of it. Like the duration less than 30 seconds versus more than 30 seconds is also being recognized as increasing the risk for future stroke risk. So during acute stroke, you can have not only arrhythmias, but also structural heart disease changes like myocardial injury, stunning. Even biopsy studies have shown myocardial hemorrhage occurring after stroke due to sympathetic overactivity. Then they are more predisposed to cardiac failure, acute MI. Acute MI in stroke, around 5% of stroke patients can develop MI during acute phase also. So that is one thing that, so it is not that just because we have a cardiology department, we are evaluating the cardiac causes. There is a specific reason why we are evaluating for the cardiac interactions in a stroke patient. And in epilepsy also, as I mentioned, the most common indication when we evaluate for a cardiac disease is when you have a suspicion, whether it is a syncope or cessation. So we all have had our like the misses when a patient with epilepsy was misdiagnosed as syncope or vice versa also. So always, and there's many of the medications which like older sodium channel blockers and all have an interaction on heart. So you can develop arrhythmias, bradyarrhythmias, especially with carbamazepine in older people. They can develop significant bradyarrhythmias and sometimes may even land up with pacemaker and all, if you don't know that drug interaction. And other entity where we see is in neuromuscular disorders, where because of the muscle, like common muscle protein involvement or electrophysiological dysfunction, they can have an associated cardiac involvement, because of which many of the neuromuscular disorders, they have a protocol that they should have an evaluation, periodic cardiac evaluation at an interval to look for the cardiomyopathy. And the treatment part, as you mentioned, because of the time limit and because it's a very vast topic, we can't cover it. There is recognition of this condition is very important for preventing future cardiovascular events or neurological events as well. So any other things to Manisha, is anything more to contribute?
Only thing is whether the channel about this, because they are the main one linking the epilepsy and other important thing is what do you want to do once you diagnose any of these symptoms from cardiac side? Do you need like early pacing or any other prophylactic techniques that can decrease or minimize the risk after like in epilepsy pain and the alcoholic series and everything? Whether you can prevent this, because from epilepsy point of view, you can only give anti-seizure medications. Cardiac point of view, the data is actually very less, but could have added that it would have been more like useful. But otherwise, yes, isn't it? And I think atrial cardiopathy also, our institute data could have.
Our institute data.
I'm sure.
Madam's publication only the criteria I had taken.
So most important channel, you have to recognize which are the medications which have an interaction with channel so that you can avoid some of the medication. That.
And we have shown an article also like sodium channel blockers and which medication particularly, and what about the newer ones? Lacosamide, all of these are cardiac effects. Because of the time probably we couldn't cover all that, but the most important thing is the erythropoietic seizure management. Like in which conditions you are advised like prophylactic pacing in these patients, and whether any other are required. And if you are detecting 6 sinus syndromes, what do you do from cardiac side? Your procedures which are being done in our institute, they are doing actually for 6 sinus syndrome and everything.
Yeah, that's fine. I think Sapna very good. Somebody has put a very valid question. How do you know whether it is seizure-induced arrhythmia or arrhythmia causing convulsive syncope? Can Sapna or Dr. Mayur answer that? Seizure-induced arrhythmia versus an arrhythmia causing convulsive syncope. Because from the
that may require a monitoring, madam. So if Mayur showed the case where in video EG there was a onset seizure followed by nictal asystole. So that
is a seizure-induced arrhythmia, because then so documented seizure then followed by an arrhythmia is the at the bottom line of the seizure-induced arrhythmia. And arrhythmia causing convulsive syncope, where we have established and ruled out that it is not a seizure. And especially a 3T MRI, which is not mentioned in that gentleman, is very important. And the insula is one of the culprit zones more than the amygdala. And then there is no seizure, but the arrhythmia per se is causing something akin to a seizure, and that could be a convulsive syncope which can easily mimic a seizure. I hope that it's clear. So somebody has raised that question here. And lacosamide, for that reason, last week also we had a patient who was put on lacosamide and then had an arrhythmia and was about to go for the electrophysiology test and the procedures as well. So I'm online, so you can just tell that to people there. That's all. Well done.
I don't know, madam, about the case.
Yeah, I also do not know about the case. I was just telling that lacosamide, since you told that old sodium channel blockers are very potent, lacosamide is 10 times even potent to cause an arrhythmia than carbamazepine and phenytoin and oxcarbazepine. So that's what I said. Okay, thank you. Good, Mayur. You can wind up.
Thank you for patient listening. We'll be winding up the session.